In this video session, we'll take the opportunity to give more specific information on MIPS and how it will affect providers in 2019. To reiterate, MIPS is the evolution of PQRS, meaningful use, and the value-based modifier into one program. However, MIPS is more than the sum of these three programs and will rank providers differently. For instance, a group that achieved 97% compliance under meaningful use may only achieve 78% in the new corresponding category under MIPS. In other words, past success in legacy programs such as PQRS and meaningful use does not guarantee good MIPS scores will be achieved. It will be essential to understand the four categories MIPS will evaluate providers on. Let's talk about each area. First, quality performance. The quality performance metric will comprise 60% of a provider's MIPS score in the first performance year. This replaces the Physician Quality Reporting System, or PQRS, and the Value-Based Modifier, or VBM program. Most providers will choose 6 clinical measures, including 1 outcome measure, to report on, which are designated to accommodate differences in specialty and primary care practices. The manner in which a provider reports measures in the quality category impacts the numbers of measures the provider will be required to report. For example, if a provider utilizes the G-Pro web interface in order to report for the quality category, the provider must report all measures included on the web interface. Similarly, if a specialty provider elects to fulfill reporting for the quality category by utilizing a specialty metric set, the provider must report all the measures included in that particular metric set. There will be some flexibility, as it will allow physicians to select individual measures or specialty specific measure sets and report through claims, electronic health record, registries, QCDR, or the group practice reporting web interface. Note that CMS is planning to provide measure benchmarks prior to or at the beginning of the performance period. The second category is improvement activities. The improvement activities will comprise 15% of a provider's MIPS score in the first performance year. This category offers the most in choice. CMS proposes to allow physicians to select from a list of 94 activities spanning 8 different focus areas, for example, care coordination or expanded access. In order to maximize achievement in the improvement category, providers must achieve a score of 40 points by attesting to a combination of activities that are weighted as either high priority activities, worth 20 points each, or medium priority activities worth 10 points each. CMS will provide accommodations for small, rural, and non-patient facing providers. Certain practices are only required to achieve a score of 20 points during the performance year in 2017 in order to maximize achievement in the improvement category. Improvement activities would need to be performed for at least 90 consecutive days during the performance period. You may want to consider implementing these at the practice level to optimize implementation and administration across multiple individual providers simultaneously.
And I would say to the physicians, get on the bus, start to learn a little bit about this. In typical CMS fashion, they've set up this carrot to sticks approach, that they do this with almost every new program they roll out, that initially the early adopters really take full advantage of the program and get most of the benefits of the program. The late adopters, unfortunately, get very few of the benefits, but a lot of the negative aspects of it. And so this will be a very, very similar approach. CMS, I think, recognizes that this will be a learning process. As you read through those final words, the words of, this is building a foundation, and we will be evolving the care of the patient, and we're learning, and all of these words that basically means this is your opportunity to start to learn about what's going to face you in a few years.
Yeah, so I love how we frame this, be part of the 20-year conversation. Don't be a late starter, because the benefit is going to go probably to those who are the early adopters. And I think in particular the way that CMS has set this program up, and this is a bit of a concern and a challenge, I think those individuals that are out of the gate early on this, because of the way quality measures improve as people start to move that. If you're behind, it's very difficult to catch up to that benchmark. You're always going to be chasing after the group who is out front. Yeah. And so I think it is important to be educated. I think it is important to realize that it's not going away, and that the country desperately needs clinician leaders to step up and say, this is how we're going to achieve this at my community, in my practice, with my patients, with our patients at our community level.
Right.
The third category is advancing care information, previously meaningful use. The advancing care information category will comprise 25% of a provider's MIPS score in the first performance year. This replaces the meaningful use program, but largely leverages the same measures. Advancing care information, or ACI, moves towards a continuous scoring system, placing greater emphasis on improving meaningful use measure performance rates by combining an all-or-nothing base score with a continuous performance score to deliver an overall ACI score. The base score, which is worth 50 points, only requires attestation or simple yes or no options. However, if any single measure in the base score is not submitted, has a numerator of 0, or the provider indicates no, then the entire ACI category will receive a score of 0. Once a provider meets their base ACI requirement, additional points are earned in the performance score category. So unlike meaningful use, where measure performance rate does not matter as long as it exceeds a single threshold, higher measure rates under the ACI performance score translate into incrementally higher reimbursement. In other words, providers should seek to maximize their performance rates for each meaningful use measure to maximize their MIPS reimbursement. Under the final rule for MIPS, data submission and performance can be assessed either as a group or by individual providers. Providers must choose to report either as a group or as individual providers across all 4 MIPS performance categories. Fundamentally, the burden rests on the shoulder of the individual primary care provider who's being held accountable to the patients attributed to them on cost and quality. And all those other people that influence that cost and the quality outcomes, that sophisticated primary care provider is going to be very concerned about who are they sending patients to, where's the care being delivered, because ultimately it rolls back onto the shoulders of the primary care provider.
Right. Which is a whole new thing, though.
A whole new thing.
When you look at cost drivers in healthcare, we've been insulated. What happened outside of our offices wasn't as much of our concern. If that patient got readmitted, came to the emergency department, spent 30 days in skilled care, none of those things were our concern.
Out of my clinic, it's not my business. Now it is.
Right.
Yeah.
Well, and I think this is where the evolution of the electronic medical record is going to occur. There was a great article recently that Michael Porter had contributed on a commentary, but if we can get to the point where clinicians at the point of care in their EMR, if I could see my Medicare cost per beneficiary right there in front of you, Mike, this is what you cost the system this year, we can then have an educated, open dialogue about, do you really need a follow-up CAT scan for that headache again? Right. Because at the end of the day, this will impact both of us. The big difference, I think, from sort of picking up where you were talking there is it's a team-based model now. And I think sort of one of my frustrations in practice for years were there are so many issues that can't be resolved in that efficient time slot that you get for 10 or 15 minutes that, the hope, and I think buried within a lot of that legislation is the opportunity to use people at the top of license. That gets used a lot, but it gives us the opportunity to dig into these socioeconomic determinants that I think clinicians have struggled with for years. And as we all know now, that dramatically impacts health outcomes. So I think it's a very intuitive opportunity, or intuitive look into what are the opportunities that are there to do better. This isn't just about clinicians, this is about a team.
I like that. I like that perspective.
And when you look at the technology that is out there that's going to waste, particularly around virtual visits and the opportunities that exist within virtual medicine and the ability to expand the capabilities of clinicians because now they have an electronic means of interacting with their patients. And yet, the real, the reins, the thing that is holding back the use of that virtual type technology is really the reimbursement structure.
Yeah.
So if we change the reimbursement structure, then suddenly, we can provide care to patients that they really need.
Yep.
We all have patients that are very engaged, that do very well with self-management.
Yep.
And we know the routine of bringing them in for a face-to-face visit 2 times a year, that becomes unnecessary with these people. They're very good. They come in because the system drives us that direction. If we're not seeing them in that face-to-face situation a couple times a year, we're somehow not providing good care. But the reality is, those are patients that would be ideal for a virtual visit, a face-to-face. How you doing? How's your blood pressure? How's your diabetes? Those are the sort of things that I see as potentials for the future.
Yeah, the opportunity, I think, is enormous to think about how we deliver care differently. Along those lines, I oftentimes hear about the penalties that are built into MIPS in particular, and we'll talk more about that. But there's an upside. There's an equal upside as well. So I think there's real opportunity. If you ignore this, if you dismiss it, I think you're setting yourself up for some substantial penalty, which I think is over time going to become enough that it really is a significant pain point.
Yeah.
But there's an opportunity on the upside that is also quite enormous. So you could do very, very well if you took it serious and measured the quality of care and delivered lower cost care. So I think that's one of the messages we'll share is there are going to be winners and losers. We know that, but you could position yourself to be a winner if you took it seriously.
And in the current system, there's very little upside. I think this idea of keeping things the same, this current PQRS value-based purchasing system is mostly a downside. If you don't perform, there's downside, but there's very little upside. CMS has put before us the opportunity to have substantial upside for performing at a high level. There's no big upside for performing at a high level in the PQRS system. So
and I think one of the challenges is the downside is so small that a lot of people are just opting not to participate.
Exactly.
Say, well, this isn't a threat for us. And so, and unfortunately, I think they're translating that past experience into the future, and they may be underestimating the significance of that strategic decision to say, well, we didn't participate before, so I don't think I have to participate now. I think that would be an error.
Yeah.
The last category, cost, is a category that replaces the cost component of the value-based modifier. Performance in the cost category will not be factored into a provider's MIPS score in the first year of performance. And providers will receive a score in the cost category during performance year 2017 in order to help benchmark to performance in future years, but the score will not impact overall performance and corresponding payment adjustment during the performance year of 2017. CMS recently released 2017 MIPS participation options, or otherwise known as Pick Your Pace options, for the first performance year of MIPS. There are 4 options for providers or groups in 2017. Option number 1 is report no data and receive an automatic -4% payment adjustment. The second option is report some data and avoid penalties. The third option is report a partial year data, a 90-day minimum, and be eligible to receive a small incentive. No penalties will be applied regardless of performance. And then the last option is to report a full year's worth of data and be eligible to receive a modest incentive. Again, no penalties will be applied regardless of performance. I do want to make a few short points. First, to recall that the program starts January 1st of 2017. Also remember that there are no changes planned for 2018 or beyond. You have to decide which option is optimal for your situation. Also, the financial impacts for MIPS over several years remain significant, and remember that even in 2017, they're highly consequential. MIPS remains financially and a reputationally competitive program. Providers who participate more strongly at the start of the reporting year will be better positioned to be successful in the upcoming years with compounding effect.